Did you know that 1 in 5 high school athletes are susceptible to getting a concussion? A concussion is a mild form of traumatic brain injury caused by a bump, blow, or jolt to the head. Stay tuned because today you will discover the pathophysiology and functional implications of TBI, examination techniques, and treatment options. Hi there, I'm Dr. Krista Burns, founder of the American Posture Institute, and your host on the Virtual Neurology Summit. The purpose of the Virtual Neurology Summit is to provide healthcare professionals with brain based solutions to recover from head and neck injuries and to improve neurologic function for your patients. I'm honored to welcome our next guest expert. Dr. Randy Beck is an internationally renowned expert in the field of clinical neuroplasticity and neuroplastic restructuring techniques. His textbooks on the subject are considered the standard in education and clinical practice in the field of functional neurology. Today, he'll be sharing with us concussion. What is it and can we fix it? Dr. Beck, thank you so much for joining us again this year on the Virtual Neurology Summit. We always appreciate having you here. Please take it away.
Uh, Thank you so much for having me, and I always look forward to this now. It's been a few years in a row, I think, that we've had this share moment. So I really appreciate what you're doing and taking information out to the clinicians and the patients and helping them live a better life. So thank you for having me on.
Okay, let's learn about concussion. So what is a concussion? Well, the actual root of the word concussion is from Latin concutare, and it means to shake together, and can be considered any event in which kinetic energy is transferred to the head. Now, concussion is very complex pathophysiologically, and it can affect the brain, and it can induce biomechanical, it is induced by biomechanical forces that cause the brain tissue, which, remember, is about the consistency of porridge, separated by some very fibrous membranes. It causes that porridge-like substance of the brain to slosh around, move around, and it disrupts a lot of the physiological connections of the brain. Now, concussion can be caused either by a direct blow to the head, okay, or blow to the body, or a sound wave production like in a bomb explosion. So it's not necessarily a direct blow to the head that causes a concussion in all cases. Most commonly it does. However, we can get people in combat having concussion from bomb explosions, people getting concussion from falls, people getting concussion from actual body impact, especially if they've already had a concussion. So that second impact doesn't necessarily have to be that strong in order to make them, in order to produce a concussion. Now, what do we know about concussions? Well, typically, in most cases, probably 7 out of 10 times, concussion is a rapid onset, short-lived impairment of neurological function inside the brain. Now, it usually will resolve spontaneously, and by resolve, we mean the visible symptoms of the concussion will resolve. And the sort of guideline that has been established is about between 7 and 10 days, these obvious visible symptoms should resolve. Now, that doesn't mean that the brain has actually healed and the concussion has not caused any other effects inside the brain. Now, there are neurophysiological changes that do occur in concussion often, and maybe even every time you have a concussion. Now, the acute symptoms, they will reflect largely the functional disturbance that has happened inside the brain. We'll talk later about the structural and functional connectivity that is involved in a concussion. But the main symptoms are from this functional disruption, not from sort of a structural injury. Now, there are, in some cases of concussion, structural injury. It depends on what your definition of structural injury is, and we'll talk about some of that stuff coming up soon. Now, it's interesting that not all concussions involve a loss of consciousness. Although, if you do lose consciousness, we're quite certain that you've had a concussion or that your brain has experienced enough disruptive activity inside those functional connections. If you lose consciousness because of that, then your odds of being diagnosed with a concussion are pretty much 100%. Now, we also know that not all concussions run the sequential course of 7 to 10 days, like we talked about just previously. But some concussions, 3 out of 10 roughly, will produce a prolonged phase of symptoms, which we then call post-concussion syndrome. Now, it's also important to know that when we're using standard imaging, sort of like X-rays or MRIs, no abnormality is usually seen in the presence of a concussion. Now, if the concussion or the head injury is bad enough, in other words, if the traumatic head injury is bad enough to cause structural damage, then a concussion has probably also happened at that point. Now, this is where I'm alluding to, is that a mild traumatic brain injury and concussion are often interchanged in science and in clinical situations. Concussion is actually a subset of the mild traumatic brain injury, which is categorized specifically by the absence of primary brain injury that we can identify with traditional methods like computed tomography or magnetic resonance imaging. And concussion obviously has a more favorable outcome than an actual primary brain injury. Now, it's also important to remember, like I was talking about before, that concussion can be caused by any kind of shaking or kinetic energy entering the brain. And so when we look at the most common causes of concussion, there are falls, motor vehicle accidents, and obviously sports related, which are really in the news these days. So basically, if we have a concussion and then we have another traumatic brain injury, which happens before the previous concussion can fully heal, we then we can get a syndrome called second impact syndrome, which greatly increases the impact and the damage caused by the second concussion, and in fact can result in death in some cases. Now let's talk about what types of injuries happen and where they can involve other components of the neuraxis. So basically, the concussion can injure two areas, and we'll start with the cortical systems and the subcortical systems. Now, this is interesting because there was a day, I suppose, not that long ago, where we didn't think that concussions involved the subcortical systems, but we now know that it does, either directly or indirectly, involve the subcortical systems, and that produces a wide range of symptoms that you might not normally associate with a concussion. So let's talk about the ones that you normally associate with a concussion first. So the cortical system, obviously in the brain, the cortex is the layer of the brain that's on the outside, usually ranging from 5 to 7 millimeters in thickness. It's in direct contact with cerebral spinal fluid. And thus, once the head shakes around, that cortex can slam against the solid structures that are surrounding it, like the skull or the falx cerebri, which is dividing the brain. So we have the lobes, the frontal lobe, temporal lobe, parietal lobes. All of them can be involved depending on the mechanism of injury. And obviously, frontal lobe is going to involve cognitive aspects. Temporal lobe is going to involve some memory stuff. And the parietal lobe will involve a lot of complex functions. we go to the subcortical systems now, including the hypothalamus, trigeminal system, basal ganglia, cerebellum. All of these can be involved, and like I said, either directly or indirectly when the concussive force travels through the neuroaxis. So let's talk about the hypothalamus, because a lot of the symptoms that we see, and I'll show you a case study later that involves some of these, but a lot of the symptoms that we see in concussion involve the hypothalamic pituitary axis in some way, and or the hypothalamic projections to the sympathetic nervous system. So we can get things like disruptions in thermal regulation, we can get changes in blood pressure control, we can get changes in sleeping patterns, sexual function, and even the creation or the development of diabetes insipidus. Now, with the trigeminal system, can be involved sometimes with facial pain or headaches. Remember, the trigeminal system, it controls blood flow into the brain. So that can result in sometimes in constriction and dilation of the arteries of the brain, which may produce headaches. Now, the basal ganglia obviously could be involved in sensory motor issues and even some emotional issues. Cerebellum, balance and posture, those are the ones that we often measure. So we want to measure the effects of balance and posture to see how severe the concussion might be. Now, the symptoms of concussion, like I said, alluded to previously, are highly variable. They can be highly variable, and they're pretty much based on the networks and structures that have been involved in the impact or the forces that caused the head to move around and caused the brain to move around, which has resulted in the way the networks have been affected. And so it's also interesting or important, I suppose, to know that symptoms may evolve over time. In fact, they may evolve over hours or days. So it's really not wise to judge the severity of a concussion at the time of the injury. It's better to wait a few days and see how the symptomatology evolves before you start categorizing the concussion severe, mild, moderate, or other types of classifications that you want to do. Now, we can look here, this diagram just illustrates the different ways in which the concussion can actually affect the body. So here we have this direct impact. So here's the impact, and boom, there's a direct impact, but then the head will swing backwards and forwards, causing the brain to slosh back and forth. So we get here the coup injury, here the contra coup injury, and we can also have a rotational component that's involved. And this happens a lot in martial arts, boxing, where the head will swing one way or the other. Now, it can happen in any sport. And it's often the rotational component that makes things worse, because now you're involving all kinds of areas of the brain, including the central components that move back and forth against that false cerebri and hitting the skull on either side. So let's talk about some of the signs and symptoms that can happen following concussion. Now, we know that we can divide them into sort of some general categories: physical and postural symptoms, cognitive symptoms, emotional symptoms, and even just sleep disruption, which is very common in many people with concussion. So the physical and postural components involve headache, some nausea, sometimes vomiting. You get sensitivity to light, maybe some visual problems due to lenses not focusing properly with the sympathetic involvement, some fatigue, which is often common, a dazed or stunned feeling, dizziness and balance problems are also common. Now, in the cognitive area, we get sort of brain fog or an inability to concentrate, a sense that your thought processes have slowed down, and you kind of have to answer questions slowly because your processing time has reduced. You get forgetful about mostly recent events, but it can actually, if the concussion is in the right area or involving enough area of the brain, you can get long-term memory loss also. You often will find people with concussions will repeat questions because they're stalling. They're repeating the question while they're trying to process the answer so that they can give it, they don't want to appear that they're not answering accurately. And you also get, obviously, if it drags out long enough, a drop in athletic performance and in academic performance. Emotionally, this is a part of concussion that lots of people underestimate, and that's the irritability that can be caused. There's a definite correlation between sadness, depression. Personality changes can often happen also. Anxiety and panic disorders can bubble to the surface. They become more emotional, or they become less emotional. They have apathy. They don't really care what happens. And then, of course, there's the sleep component. They're feeling drowsy when they shouldn't. They're sleeping more or sleeping less, depending on the involvement area of the brain. Difficulty falling asleep and difficulty staying asleep. So a lot of symptoms can come from the concussion relating back to those areas of the brain that we just discussed. Now, how do we measure the effects of concussion? So once someone has been diagnosed with a concussion and we feel that that's what they have, how can we find out, how bad this thing is? Is it healing? Is the treatment we're doing working? So we have a lot of neurophysiological tests, electroencephalogram, polysomnography, brainstem auditory evoked potentials, electro and video and stimulography, vestibular evoked myogenic potentials, somatosensory evoked potentials, transcranial magnetic stimulation. And then we also have pretty exciting developments in some biochemistry stuff, so blood protein biomarkers, where we're looking at things like angiotensin and other common proteins that are released when the brain is injured that shouldn't be sort of in the blood of the brain. Okay, so a lot of really, really interesting research is happening in that area. So I think there's going to be some breakthroughs made there in the near future. Now, I was talking before about the functional and structural connectivity of the brain. And so I'm just going to go into that a little bit. It's a really, really important area, I think, that's starting to emerge. So the two types of connectivity that are inside the brain are structural connectivity, which is basically the anatomical organization, the axons and fiber tracts that connect. And it can be quantified or non-invasively measured using things like short and long-term tract tracing procedures like diffusion tractography, which I'll show how we can connect tractography and some other things together in the next slide. But functional connectivity refers to the statistical dependence between the time series of electrophysiological activities. So what's that mean? That means basically how fast these signals are traveling between these two structures that are normally connected and normally have a set communication time. And so if you get disruption in axons, that obviously that connection speed can reduce or it can actually be eliminated, it can stop. If you get disruption in the dendritic areas, then also the time to produce an extra potential can change because the dendritic involvement in the production of generator potentials in the cortical neurons, it might be interrupted. So you get all kinds of weird things happening when you have a concussion. And we get into this in a lot more detail in the diploma program that is offered by the Innovative CEU, which if you wait around to the end, we can show you how to contact them. But basically, we can look at how the connectivity is how the connectivity has been affected by using an EEG or a MIG. Now, EEG is a lot more clinically useful or clinically easy to use. MIGs are very difficult to transport and to measure actual activity in the brain. So that's why we use EEGs at the Institute. And you can measure all kinds of variables with EEG, like split half-time measurements. You can measure coherence. You can measure phase lag, phase shift. A lot of different things that can indicate what structures are involved and how they've been injured. You can also measure gross amplitude measurements, which are a direct indication of the number of neurons that are involved. So the EEG gives us a lot of information. And also you can use an MRI. Usually you want blood oxygen level dependent contrast or bold. And from those measurements, you can measure the metabolic demand, which gives us a direct insight into, or indirect insight into the neural functioning, whereas the EEG gives us a direct insight. So we are experimenting with linking these structural and functional components. So we use the tractography that tells us where the connections are and how the axons travel from one place of the brain to the other. We use the EEG to measure the activity in those areas. And when we put the two together, we can get a pretty accurate output of where in the brain the problems are and how bad the problems are by measuring the amount of activity in those areas. Now, just going to talk very quickly about clinical management of concussion. So it's really the clinical management is broken down into three, I would say four maybe, components. The first is the immediate care. So if you come across the person, they come into your clinic, you're on the sidelines of sport event. First of all, you have to recognize that the player may have sustained a concussion. And if you feel they may have sustained a concussion, they should be removed from activity for further evaluation. And then you want to take care, do the first aid of any bruising or fractures, lacerations, anything that might have happened from either the fall or the impact that they have experienced. Now, diagnosis is the next component. So you need to use multiple evaluation tools, such as symptom scales and checklists. So there's a lot of psychological checklists. There's a lot of symptom checklists that you can use. You can do balance testing. EEG, neurocognitive assessments may increase the sensitivity and specificity of identifying where the concussion has occurred and potentially how bad the concussion is. And then we get into the restorative processes. So rest, balance and cognitive training, nutritional supplementation, brain stimulation techniques. So you can use adjustments to stimulate the brain. You can do peripheral stimulation, vibration, electrical stimulation, or you can use direct stimulation like a transcranial direct current stimulus. And then you also, if the symptoms persist, you need to start thinking about symptom management, treating symptoms such as headache, depression, sleep disturbances, difficulty concentrating, all of the symptoms that we've listed before. And you treat those much the same way that you would in your clinical practice. Now, we're going to do a case study quickly. And this case study is of an AFL player. Now, AFL is Australian rules football. And it's a pretty active game, fast moving. it's kind of a combination between soccer and rugby, I suppose, and high impact collisions and like I say, fast moving, strong players. So we get a lot of concussions happening in this sport. So this is a particular case study. It's a 19-year-old AFL player was concussed twice in the same game, lost consciousness after the second concussion, and he presented to our clinic about 3 weeks later when the symptoms continued to persist. So remember, the guideline is 7 to 10 days. After that, if the symptoms are persisting, we start to think that this may be a problematic event. Now, I'm going to just take you through some of the measurements that we made, and you can see the changes that have happened in those. Basically, he was treated for about 3.5 months. Okay, so you'll see when he first started, his perception of balance was about 30%. Okay, and then as we progressed through the treatments, he reached almost 100% at the end of the treatment. Now, the treatment involved was very simple. It was simply manipulation, so adjusting based on the EEG findings and the physical findings. It was using peripheral stimulation, vibration, electrical stimulation, interferential current, using deep tissue triggers, and some silent therapy, some cerebellar stimulation, vestibular stimulation, and some cognitive stimulation later, in which we had him visualizing catching the ball over one shoulder or the other. Okay, so it was pretty simple. There was also nutritional supplementation. We did, in this case, vitamin B12 complex, fish oil, probiotic because of the gut-brain connection. We also did glutathione and coenzyme Q10. So next area I want you to look at is the frequency of headaches. So when he first came in, headaches were, he was having roughly what he would consider, maybe 50 headaches a month, which is more than one a day. That's pretty intense. And then as the treatment progressed, he dropped radically down to about 10 a month. So two a week, still not that great, but better than he was for sure. And then we look at, this is an interesting one, blood pressure. So when he first presented to the clinic, his blood pressure was 160 over about 90. Now this is a 19-year-old physically fit person, and you wouldn't expect that blood pressure to be up like that. And this is basically because of the brainstem the PMRF that was involved in this concussion, resulted in a release of the sympathetic system, which caused his blood pressure to rise. Now, as we went through the treatment, you'll see at the end, his blood pressure was 120 over about 78, which is more what you would expect for a person in that physical condition and age. And finally, it was happiness and well-being. And this is interesting because when he first started, he rated his happiness and well-being at around 18 out of 100, 18%. And, this is a young man in the prime of his life. He's made it to the epic epitome of his sport. And he is, living life high. And he has a feeling of well-being and happiness below 20%, which is terrible. And by the end of the treatment, he was back up to, relatively where we would expect him, 85% or so. So that's a case study. Just used these little diagrams to illustrate the components or the neurological functional projection systems that were probably involved. So you can go back and have a closer look at those. Now, if anybody wants to get some contact information, so we do have an affiliate clinic program in which we help clinics establish functional neurology treatments. We have a diploma in clinical neuroscience, which is a 1,200-hour clinical diploma, and you can access that at, you can contact us at ifn.net.au, or you can go straight to the Innovative CEU platform and sign up and take the program. And of course, anything you want off the website, we've got information there. So now we'll take some questions.
Dr. Beck, thank you so much. That was an excellent presentation. As always, we learned so much about concussion, which is such an important and on-point topic. I'm going to do a quick summary and then a couple questions for you. So you talked about concussion being from the Latin root concutire, which is to shake together. So complex pathophysiologic process affecting the brain induced by traumatic biomechanical forces. It can be due to a direct blow of impulsive force or an impulsive force transmitted to the head. And concussions typically result in the rapid onset of short-lived impairment of neurologic function that does commonly resolve spontaneously in about 7 to 10 days. However, it may result in neuropathological changes. And the acute clinical symptoms largely reflect the functional disturbance rather than a structural injury. Results in a graded set of clinical symptoms that may or may not involve loss of consciousness. And the resolution of the clinical and cognitive symptoms typically follows a sequential course. However, post-concussion symptoms may be prolonged. And with a mild traumatic brain injury, so a concussion is actually a subset of mTBI, and there's 3 common causes of concussions, which are falls, motor vehicle accidents, and sports-related issues or injuries being the most common. And second impact syndrome is when a TBI occurs before the symptoms associated with the previous concussive injury have not yet completely resolved. So of course, that can be much more severe. And of course, we want to prevent that from, for example, our athletes starting to play too soon, which could lead to another concussion. And then injury to the neuraxis. So with a concussion, we have cortical and subcortical systems that can be impacted. So cortical, we have frontal lobe, which can impact cognition, temporal lobe, memory, parietal lobe, those complex functions. And for subcortical systems, which have been overlooked, so it's important to, if the patient is presenting with these symptoms, of course, to bring that back to the concussion. So with the hypothalamus, disturbance, we can see things, disturbance in thermal regulation, blood pressure control, sleep pattern, sexual function, and diabetes insipidus. With trigeminal system, head and facial pain, headaches and facial pain. Basal ganglia can impact sensory and motor, and the cerebellum can impact balance and posture. And then some symptoms. So it's highly variable patient to patient, but really it'll be somatic, vestibular, affective, and vegetative features. And symptoms may evolve over the hours to days after a concussion. I think this is a really important point, not to just judge the severity of the concussion at the exact time of injury, but to follow the patient over the course of days and weeks to see if they have evolving symptoms. And then the direct impact, acceleration and deceleration and or rotational forces can all occur, and rotational can make the symptoms even worse. And the signs and symptoms to look for, so we have physical and postural symptoms such as headache, nausea, vomiting, sensitivity to light, visual problems, fatigue, dazed, dizzy, and balance problems. With cognitive, the patient has difficulty concentrating, they have brain fog, they're answering questions slowly, they may repeat the question, forgetful of recent events, and they may see a drop in academic performance. And with emotional, they can be more irritable, sad, depressed, they see personality changes, or their family may notice personality changes. Anxiety, more emotional. Also, they could be less emotional or apathetic. And for sleep, drowsiness, sleeping more, also sleeping less, difficulty falling or staying asleep, so difficulty in that sleep-wake cycle. And then measuring the effects of concussion, so we have multiple different forms of measuring, such as EEG, PSG, brainstem, auditory evoked potentials, somatosensory evoked potentials, transcranial magnetic stimulation, and blood protein biomarkers. And measuring connectivity following concussion. So the brain has both structural and functional connectivity, and structural connectivity is really the anatomical organization. Functional being the statistical dependence between the series of electrophysiologic activity. So that basically means how fast the signals are transmitted among the neurons for functional connectivity. And a link between structure and function, so you're able to show us the tractography and the DMRI, and that shows not only where the problems are, but how bad. And so that was really insightful for determining, where the problem is located, but also how it's impacting the function. And then for clinical management, there's immediate care, which is removing the patient from activity, diagnosis using multiple evaluation tools, scales, and checklists, doing balance testing, EEG, neurocognitive assessments, for example, and then restorative process. So rest, balance, cognitive training, nutritional stimulation, brain stimulation techniques, and symptom management. So if the patient has symptoms beyond, for example, headaches, we want to treat symptoms such as headaches, depression, sleep disturbances, and difficulty concentrating. And you shared with us an amazing case study showing that those phenomenal results that you were able to get with the patient. And of course, thank you for sharing with us more about the Institute of Functional Neuroscience. And I want to encourage everybody to be sure and check that out, because if you are interested in learning more about functional neuroscience, Dr. Beck is the place. That's the place to be. And Dr. Beck is an amazing professor in sharing with us so generously each year in the Virtual Neurology Summit. I know we always learn so much, and it would be amazing to get that full certificate and get that mentoring. So thank you for sharing with us those resources. All right, a couple of questions for you. When it comes to treatment, I know you said for clinical management, there's the 4 phases, which is immediate care, diagnosis, restorative, and then symptom management. How long after the concussive event occurs are you treating the patient? And how long after are you allowing them to rest before doing brain stimulation? What does that look like with the time frame?
Right. So usually you will, if you're lucky, you can get the patient in within that 7 to 10 day period. Generally, the way things sort of work out in real life is that they don't usually come in until after that, because they're kind of waiting to see if the symptoms are going to go away. They've been told rest for 7 days or whatever. Even mild exercise sometimes will generate a headache in that sort of 7 to 10 day period. But after the 10 days, we start to see a rise in the people attending the clinics, just because they're starting to get a bit worried. Symptoms aren't going away. And so generally they're already in a more difficult classification. Okay, so by the time they come into your clinic. But occasionally, if you're lucky, you will get them in that 7 to 10 day period. Basically, if it's someone a child's friend, whatever, family friend, they'll generally bring them in right away, just because they want to get a quick evaluation. So my general rule of thumb is the sooner you can get them, the better. And then what we do is we run an assessment, we run the EEGs, that kind of stuff. So kind of gives us an idea of what we're dealing with right away. Okay. But as I will stress this, do not make your diagnosis, or especially with the classification of how bad things are, until sort of that 7 to 10 day period is gone, because you'll make mistakes if you do that. And that's not something that you want to have over your head, making a mistake with someone like with a brain injury.
Yes, absolutely. And thank you for sharing with us that. I think that's a really important point, especially if you're on the sideline and saw the injury take place, for example, or if, you got the call and, the injury just happened that morning or yesterday morning and, the patient comes in. I think it's easier to perhaps make assumptions about their prolonged symptomatology if you actually saw the injury or heard about the injury. However, it's important to have the objective assessment and determine those the symptomatology and the range and the course of their treatment based upon the objective measures. Really important.
Yeah. So back when I was in Canada, I was sort of at a pretty high level of management of junior A clubs and things like that, where we get lots of concussions and lots of head injuries and all that kind of stuff. So that was a real good place to cut your teeth on. You see these heads just get bashed, and even in fights where they pull the helmet off and then the kid falls down and hits his head on the ice. It's it's pretty terrible, really, to see that all happen, and then have to try and evaluate it right away, because you remember a lot of the time they'll have huge amounts of adrenaline
Yes.
running through them.
Mhm.
And that kind of hides some of the symptoms, and it blurs how bad things are sometimes. So you really have to calm everybody down and just take a few days and then start evaluating them.
Yeah, that's a great point. A combination of adrenaline plus the desire to get back out and play for so many athletes. They're in the hype of the game. Maybe there's just a few minutes left, and they have that desire to get back out, even though they need to be rest and have those objective findings evaluated.
Well, I will tell you that the second impact syndrome is real.
Yes.
And we actually had a young man die last year here in Australia because of second impact syndrome in an AFL game. So it's real, and you really have to, respect it.
Mm-hmm. Absolutely. And that comes down to the education too. Fortunately, there is more education in the media, for example, about concussions. I think it's at the forefront of more athletes in particular. But of course, if somebody suffers a motor vehicle accident or something, they may not have that education. So it's about that education to have full recovery before going back out and play and being exposed to the potential of another injury to prevent that second impact.
And I'll just put in just one more final comment, because what you just did was so important. Because just because the symptoms go away doesn't mean there's not still a brain injury.
Yes.
Okay. And we're finding now differences in propagation speeds, difference in network connectivity out to a year after the symptoms have gone away.
Wow. So
it's really important to, and this is maybe why we have like boxers who have continuous, concussions, or NFL players who repeatedly get concussed, and they may not have symptoms that they can feel at the time, but the brain is undergoing these constant re-injuries that are building up over time and developing scar tissue and releasing, and that's why the blood chemistry stuff is so important, because we're finding now that we can detect these things over time with blood assays, particularly ones that measure not just plasma but blood cells, like red blood cell components.
Very fascinating.
Yeah, it's going to be, I think, a field where we're going to get some good answers.
Yes. And we've already seen the evolution. I think, many of us can reflect back to our own childhoods thinking, yep, I probably had multiple concussions and we never did anything about it. And then now at least it's at the forefront of education when it comes to athletes in general. But now I think that we're going to be seeing even more evolving treatments and assessments. Excellent. Well, thank you so much. And as we wrap up another great session today in the Virtual Neurology Summit, I'd like to acknowledge Dr. Beck for his excellent work in pioneering the field of functional neurology. And to all of our viewers, I'd like to acknowledge you. Thank you for your commitment to brain-based correction and objective clinical results. I'm Dr. Krista, your host on the Virtual Neurology Summit. Be sure to check out the Postural Neurology program to get certified in brain-based postural correction. Stay tuned, and we'll see you on the next Neuro Masterclass of the Virtual Neurology Summit.